Good morning, colleagues. My names have not changed. They are still Raji Tajuddin Mohammed. I work for the African Union, and I head a division at the Africa CDC. So, colleagues from Francophone countries, I say bonjour. For those from Portuguese speaking, I say bom dia. And for those from Anglophone, I say good morning. So let me once again, on behalf of John Nkegasong, Director of Africa CDC, welcome each and every one of us to this very, very important workshop, which was one of the critical pillars as far as the strategy to respond or to prepare and respond to COVID-19 is concerned. So next. So this is the outline. First, I will take you through what is COVID-19. Let me say, to remind you what is COVID-19, because as Osman said earlier on, this is not about the presenter talking to everybody. It's an interactive session, so we are all going to gain from one another at the end of the day. As we all know, the COVID-19 itself is something that is still evolving. A lot remain unknown. So what is known to you may not be known to me. So that is why it's an interactive session. So it's a two-way flow. So this is the outline. First is what is COVID-19. Two, what is the situation globally and in Africa. My colleague from WHO will take you through what is happening globally, but for me, I'll focus more on Africa. Then, of course, as Africa CDC, a public health agency on the continent, what exactly are we doing? And the political platform for Africa CDC, that's the African Union Commission, what sort of support are they also providing in terms of preparing and responding to this COVID-19? Next. So, by way of reminder, we all know that the COVID-19 is the name of the disease. And the virus that is causing it is known as SARS-CoV-2. And of course, we know that it belongs to the family of coronaviruses. And in terms of epidemic significance, the COVID-19 is a third after one, the severe acute respiratory syndrome, then the Middle East respiratory syndrome. So now we have the COVID-19. And of course, we know that it's of zoonotic origin. But what is debatable or what is not known is what exactly is the source. In terms of the primary host and the intermediary host, we are not very sure. But of course, there are a lot of speculation that possibly is from bats. And in terms of intermediary hosts, a lot of debate is going on. And of course, we know that the epicenter is from Wuhan, Hubei province in China. And we know that it started in December 2019. And in terms of clinical manifestation, we know that primarily it affects the respiratory system. And the manifestation varies from common cold in the mildest form to severe respiratory failure in the most severe form. That will involve some support for ventilation. Next. So, why is it transmitted? What is known to us is that this is a respiratory droplet infection, usually from an infected person, either by way of coughing or sneezing. And of course, we also know that contact with either the individual that is having the COVID-19 or contaminated surface can predispose to this infection. And we also have, though not very strong evidence, that there can also be asymptomatic transmission. That is transmission from people who are not symptomatic, but that is still debatable. Next. So, in terms of spectrum of the disease, we know that 80% of people with COVID-19 we have very, very mild symptoms that is compatible with day-to-day activities. And what is also known to us is that 14% we have severe disease that will require hospital admission, and we know that 5% is going to be very, very critical. We require some sort of intensive care management. And we know that older adults tend to suffer more in terms of severity of this disease, and in terms of requiring some sort of ventilatory support or pulmonary support. And we know that people with underground or background medical conditions like diabetes, hypertension, cardiovascular disease, chronic renal disease, which also suffer severe or fatal form of the disease. Yeah. So, what is the case fatality rate? Of course, this varies from one place to the other. But what is known is that generally it's around 2 to 4%. So the average there is around 3.4%. And we know that for people above the age of 70, the fatality rate or case fatality can be as high as 15%, meaning that between 1 to 2 out of 10 can actually come out, very, very bad, very severe. And we know that in people below the age of 40, it's slightly less severe. We're talking of case fatality of 0.2%. And as of yesterday, we do not have any fatality in people below the age of 20. So which means that this is a disease of the elderly. Okay, so moving on to the next part of the presentation, that situation globally, and with a focus on Africa. As of yesterday, the total number of confirmed cases globally is in excess of 115,000 in more than 110 countries. And in terms of number of deaths, we have more than 4,000 fatalities. And of course, you can see the distribution in there. So you can see the distribution. Virtually every continent has been affected, from Asia to Europe to America and to Africa. So, coming down to where we are, Africa. Currently, or as of yesterday, there are 106 cases on the continent of Africa. That's from Cairo to Cape Town. There's only one death so far in Cairo, and 11 countries so far have reported cases. You can see the distribution there. Leading the pack is Egypt with about 59 cases, followed by Algeria with 20 cases. Then, of course, we have Senegal with 4 cases. Then others, okay, we can see South Africa down there, about 7 cases as well. So that's the picture as far as our continent is concerned as of yesterday. I'm sure this morning things will have changed. So I'm still waiting from headquarters to send us the situation report for 11 March so that we can update it as appropriate. When Usman was presenting, he said COVID-19 is not just a medical issue. It's not just an health issue. It's something that has implication on our socio-economic sector, especially in Africa. In Africa, we talk of Agenda 2063, the Africa we want, come year 2063. And that's our own socio-economic blueprint of where we want to be. So with this COVID-19, we know that it will be a challenge to achieve that if we do not collectively address this COVID-19 as an issue, on the continent. So globally, it's estimated that if we not do anything, in terms of economic losses, we are talking of $300 billion US. You know what that means, And of course, in terms of businesses, we talk of serious businesses. More than 5 million businesses will be impacted one way or the other if we do not do anything. And of course, we have some notable quotations or some notable expressions from some authorities as far as public health is concerned. Peter Piot, in one of his presentations, said that it's inevitable that cases will emerge in Africa. That was then, when there were so many speculations, so many theories that possibly COVID-19 will not affect us in Africa. We are always last when it comes to everything, including COVID-19. So, he said it's inevitable that cases will surely emerge in Africa, given the large amount of traffic between Africa and China. That was then. And you also now know that This statement is still correct up till now, but with some modification. Even our colonial masters too are also what? They are also suffering. So meaning that whichever way you look at it, either by way of our relationship with China or our relationship with our colonial masters, we are still what? At risk. And of course, is there any risk that what is happening now is going to become global pandemic? According to Anthony Fauci, that's the U.S. National Institute for Research and Allergy, the boss there, he said that it's just a matter of time. You know, and I'm sure we're all witnessing. I mean, we're all seeing what is going on. It's fastly evolving, so it's just a matter of time we will get there. So, then the last but not the last, the last but not the least cause there is saying that if the virus is not altered, it could infect 60% of the world population and kill 1 in 100 of those infected. We are talking of 50 million people. So meaning that we really need to stand up and address this preparedness and response with all the energy, that we have in us. So, what exactly are we doing as Africa CDC and African Union Commission? Next. Oh, sorry. So, one, in terms of risk, let me have that. Use this. Sorry, when I'm presenting, I like moving around, but I know that we have interpreters, so when you have interpreter, it doesn't allow you that opportunity to move around because you have to speak to the speaker for them to be able to interpret. So, in terms of vulnerability, we know that in Africa, we are quite vulnerable, for a lot of reasons. So, one is that where this epidemic is happening now, most of them are our trade partners. I don't think there is any country in Africa that does not have one thing or the other to do with China today. So, and that again has implication on be it economy or the health index on the continent. Because it's just a matter of time, if you don't have the virus today, with continuous traffic, one day you get an imported case. Two, in terms of infrastructure, financial, again, most of us, our infrastructure are largely driven by either China or European countries. And so with this infrastructure development comes what? Personnel. So all this make Africa much more vulnerable to this COVID-19. Of course, I've talked of flight traffic, but more importantly, we need to know that, when SARS happened in 2002, it took almost 5 months or thereabout before Africa was affected. When the H1N1 also came on board, it took us almost 2 months or so before we were affected. So we were last, and the reason that time was that Africa was not that connected to most of these other places. So between that time, that's 2010, 2019, the air traffic or flight traffic between Africa and China has gone up by 630%. We talk of about 8 to 9 flights leaving Africa every day to China. So we are much more connected or interconnected than we were 10 years ago. And of course, we know that all this has what? Public health implication. And COVID-19 is not an exception. Of course, in terms of health facilities, we also know that we are not where we are supposed to be in terms of health facilities. We know that close to 50%. Perfect. So, we know that about 50% of our member states do not have access to modern health facilities. We know some countries that do not have one single mechanical ventilator. So, what happens when you have somebody with severe COVID-19? And you know that to transfer a patient with COVID-19 from one country to the other, that person cannot go by commercial flight. You need air ambulance. So for those of us that were involved one way or the other during the Ebola outbreak, you know how much it costed then to transfer one patient with Ebola from Sierra Leone to Nairobi at that time, as the medical coordinator for the African Union Support Ebola Outbreak in West Africa. I had to release 72,000 USD to transfer a patient, from Sierra Leone to Nairobi, to Kenya. And this was not even an Ebola patient. This is a patient that was, this is a volunteer that was there but had an issue. So we had to send him back to, his home country. But just because it's coming from Ebola-affected country, no commercial flight was ready to pick this guy. So we have to go by air ambulance. And that alone costed us 72,000 USD. So now imagine if it was an Ebola patient, so coming down to COVID-19 now. So for a country that cannot afford one mechanical ventilator, we think that country will be able to afford transferring a patient? And again, which country is even ready to accept that patient? So a lot of huge implication on our health system. When you also talk of health financing, in 2003 in Abuja, the health ministers met and agreed that 15% of our GDP, 2003, I repeat, that 15% of our GDP should go into health. Up to this moment, how many countries is even spending 5% of their GDP on health? So that's also a very huge implication on this COVID-19. In terms of human resources for health, you agree with me that we are still far from where we are supposed to be. The other time we were debating that field epidemiology training program, WHO said Africa should have minimum of 1 per 200,000. We said it's an insult on us. Why should we say 1 to 200,000? How can one handle 200,000? I know. Let's redefine that. Let's make it more tighter. But the reality is, a lot of our country do not have up to that. So again, now imagine if what is happening in Italy now is happening in one of our member states. What do we think will happen? So these are all huge implications for this COVID-19 outbreak on our continent. But so far, it's been so good. So meaning that we have to continue to put in place a robust preparedness. And for those countries that are already affected, we need to continue to tighten our response mechanisms or systems. So in terms of vulnerability, a study was done by colleagues from UK around the middle of February to look at which countries in Africa are more susceptible, so that we know in terms of channeling resources, which country do we start with immediately, and which country do we move next, and so on and so forth. And from that study, it was discovered that the countries most at risk, 1, Egypt, 2, Algeria, 3, Nigeria, 4, Ethiopia, 5, South Africa. Those at very high risk. There are about 11 or so of those countries, So again, the implication of this study is that we are not completely immune against COVID-19. It was just a matter of time. And you agree with me that of these 5, 4 is already affected. So meaning that this prediction is becoming true. And not only that, even the dynamic, the scenario is changing, because at that time, the only place where you have community transmission was China. Now we have Italy, we have Iran, we have South Korea, we have Japan, and you know that all these countries have one thing or the other to do with our member states. So meaning that the risk now is much higher. It also means that more countries, are going to be at risk of this COVID-19. So it's not just one person's issue, it's everybody's problem. So for Africa CDC, what exactly are we doing? If we all remember, on the 30th January, Dr. Childress, WHO DG, declared this outbreak a public health emergency of international concern. I believe we all know what that means. And shortly after that, the Africa CDC set up a task force, a continental task force. We call it African Task Force for Coronavirus Preparedness and Response, short form AFCOM. And under this task force, we had 6 working streams or technical working groups to oversee 1, surveillance, and this is led by Kenya as a member state. We have clinical care, led by South Africa, infection prevention and control, Nigeria, lab diagnosis and subtyping or sequencing, led by Senegal. Then, of course, risk communication and community engagement, which is led by Morocco. So these were the different working stream. Supply chain and stockpiling. So this, we left it at the headquarters, Africa CDC, to work in conjunction with UNICEF and UNOPS, because we know that this may be very, very difficult for one member state to take the lead. So, and it's also very strategic. It requires a lot of resources. So that is ours at the headquarters. So our goal that time was, in the short time, to make sure that at least 35 member states have minimum capacity required to address these 6 key areas, be it surveillance, clinical care, IPC, lab, and the risk communication. To also ensure that we have 50 rapid responders. These are expertise that have been trained and housed within the roster of Africa CDC. We have what we call the AVOC, African Volunteer Health Corps, and this is something that has been adopted by our head of state. So currently we have close to 800 people within that roster. So our near-term goal, short-term goal is to make sure that 50 of them have been pulled to the headquarters and ready to be deployed to support member states. And of course, in terms of stockpiling, to make sure that we have substantial stockpile to assist or to support those member states with a weak health system. If you remember when Dr. Childress was declaring this outbreak a public health emergency of international concern, he said they were not doing that because of China or those developed countries that were affected. They were doing that because of the implication of COVID-19 getting to those countries with very, very weak health systems. You know, and this has always informed what Africa CDC is doing. And you agree with me today that if you are asked to list 10 countries with weak health system, I'm sure 7 out of that 10 will be from Africa. So this is what is actually driving what Africa CDC is doing. And of course, even if you say you are strong, we want to carry out some sort of response simulations to know how capable, how ready you are. So, so these are our short-term goals, and to be able to do this response simulation in 4 of 5 African Union regions on the continent. So this is just a brief summary of our of what we've been doing since this outbreak started. On 23rd January, that's the Africa CDC director there, John Nkegasong. Sorry. Yes. Yeah, but it's not going. Okay. Yes. So on the 23rd of January, before this outbreak was declared a public health emergency of international concern, we updated the 5 regional collaborating centers. At the Africa CDC, we have 5 regional collaborating centers across Africa. We have 1 in Zambia for the Southern African countries. We have Kenya, we have Nigeria, we have Cairo, and we have Gabon. On 27th January, before WHO declared this outbreak a public health emergency of international concern, the Africa CDC Emergency Operations Center was activated because we knew that it was just a matter of time. It will affect us. On 28th January, the first briefing of member states took place. Member states mean each and every one of us here. So we had a meeting there to brief everybody in member states and to agree on a joint approach towards preparedness and response. Then, of course, on 14 February, a ministerial meeting was conducted in West Africa with support of WHO and Africa CDC in Mali, because we know that this is just not an health issue. For you to be able to mount a very robust response, you need all the necessary political support. So the first ministerial meeting took place in Mali. You know, that's for the West Africa sub-region. And just last week, I think the Southern Africa also had the same thing. Central Africa also had the same ministerial meeting. On 22 February, the chairperson of African Union Commission, Musa Faki Mahamat, also conveyed the same ministerial meeting at the continental level. All the 55 member states were in Addis Ababa to agree on a common approach to this COVID-19 outbreak. So, for the ministerial meeting, so these were the outcome. One is to endorse our continental strategy. Two was to also support the task force that has been put in place. Three, we came up with the different technical working groups at the formation of the task force. So all these working group were also endorsed by the ministers. Of course, we know that if we talk from morning till evening without financial resources, we are not going to make any inroad. So we also agree on how do we mobilize the needed resources for this response. And of course, the importance of coordination, collaboration, communication, and cooperation was highly emphasized at that meeting. We know that there is no single country that can do it alone. In fact, for COVID-19, there is no single continent that can do it alone. So we need to work together, and that was seriously emphasized, you know. And just to shed a bit more light on that, in terms of our coordination, we are working closely with China CDC. As I'm talking to you now, we have a senior technical advisor from China CDC that is working closely with us at the Africa CDC. We are also in constant touch with European CDC. Every week, we have a regularly scheduled meeting with European CDC. And we're also working closely with WHO Afro, WHO EMRO, and WHO Geneva. In fact, the director of Africa CDC is one of the 6 envoys that has been appointed, you know, to oversee the preparedness and response to this COVID-19. So, which also emphasized the need for us as member states, especially when we are coming from the same region, the need for coordination and collaboration. Okay, so in terms of what we have done, because I'm sure some people say these international organizations, they do more talking than action. We know that COVID-19 is not the time to talk. It's the time to act. It's the time to walk the talk. So, in terms of what we've done, in area of surveillance, which is one of our main work streams, we were able to bring together partners, member states to Kenya, and we were able to build capacity along the line of surveillance, especially at points of entry. And in that particular workshop, we had 7 of the major the airlines in Africa. You can see them there. You can see Kenya Airways. If your national carrier is not there, it's not an offense. We are talking of major carriers here. So we have Kenya Airways, we have Ethiopian, we have South Africa, we have Rwanda. About 7 of them were part of that meeting. And still in that meeting, we had ICAO on board. We had WHO. So that's one of the trainings we did. In the area of lab, we have also built the capacity of more than 40 member states. Currently, more than 40 member states in Africa have what it takes to test for COVID-19. They also have the test kits. In fact, for all the member states that have recorded one case or the other, they all, before the case came on, they are already developed their capacity to test for this COVID-19. So I think that's a big plus for us. And this courtesy of WHO and Africa CDC working jointly together. So the first training was in Dakar. And at that time, we had only 2 member states that had that capacity, just Senegal and South Africa. So after that training, about 15 member states, had acquired that capacity, and we also, not just that you have the capacity without the resources to do the test. So African Union and WHO gave a lot of test kits to this country. USCDC also sent test kits to this country. So currently we have 43 countries with that capacity to do the testing. And hopefully before the end of March, all the 55 member states will have that capacity to do this COVID-19. Because that's the basic requirement. If you cannot diagnose the disease, then how do you move forward? So by the end of March, we will have, every place will have become green as far as this testing for lab capacity is concerned. Okay, so this is the lab capacity. You can see how we moved from 2 countries to 43 countries. Yes, in terms of infection prevention and control, I'm happy to say that we have some of our colleagues that we did this together in Abuja, Nigeria, in the house here. So that's a welcome development. And that also emphasizes the fact that these different working groups are actually closely interrelated. If you're IPC, you need to talk to your colleague in case management. If you're in case management, your colleague in surveillance and lab, you need to work closely, together. So in terms of IPC training, we have done 23 countries across Africa. Some of the countries here have acquired that training. Currently, about 16 countries are undergoing that training in Abidjan, Cote d'Ivoire. They also started today. Just as we are rolling out this one, they're also rolling out the lab training in Abidjan. And the target individuals here are the IPC focal point for the country, and the IPC at the point of entry. Because the emphasis here is that when you train people, you want them to go back, put in place a plan, to make sure that that capacity that an individual has acquired can be cascaded down to subnational level. And I'm happy to inform you that a lot of countries have actually done step-down training when they went back to their respective countries. Now, we know that one of the challenges we have with this COVID-19 is communication. Because there is a lot of misinformation going on, especially in the social media. There's a lot of rumor, a lot of stigma. And if as the primary responders or the front runners as far as responding to this outbreak is concerned, we do not own that space, then we are going to lose that battle. So this explains why risk communication and community engagement is one of our main strategies to respond to this outbreak. And so far we have trained 25 countries. This training took place in Tunisia. And sometimes, maybe next week or so, the third training, because our target is to make sure that all this basic capacity, we have 35 countries, that's 2/3 of the countries in Africa have acquired this capacity. So the third training is going to come up in Marrakesh. So please, if you are invited, endeavor to attend. It's very, very important. And it's one of the places that we're really, really struggling. Because a lot of rumor is ongoing there. In my country, somebody said, just keep drinking garlic. You will never catch COVID-19. Somebody will tell you, keep bathing with, what do you call it? With salty water. And that bath must be 4 a.m. in the morning. So you can imagine all sort of rumor going on. So we need to own that space, And for us, all of us here too, as part of this package, we're going to, equip us with that basic minimum requirement for risk communication. Because everybody needs to have that kind of skill. Because you can imagine, the people out there do not know who is an expert in lab or who is an expert in clinical care. You are a medical person. At this COVID-19, they keep bombarding with all sorts of questions. So you should know what exactly to tell them and how to tell them. very, very important. You know. So, for the lab, we have also decided to move a step further by selecting some countries and equipping them with that skill and knowledge to be able to do sequencing. You know, and one of the things that one is proud about is that when Nigeria detected this case, they actually did the sequencing themselves. They did not have to send that sample to US CDC or Public Health England or anywhere. That sequencing was done in Nigeria. You know, so we are moving forward in 6 countries, from Morocco to Nigeria to Ethiopia, and Zambia is also one of those countries, you know, with that capacity to do sequencing. So if in your region, you have COVID-19, you don't need to go to US or to UK to be able to do sequencing. Your neighbors should have that capacity. And currently, we are linking Nigeria and Cameroon together so that the sequencing for those Cameroon cases can be done in Nigeria. So, for Africa CDC, of course, we lay a lot of emphasis on regional approach, you know, and the reason is very obvious. We know that in terms of capacity, there will be differences from one country to the other, you know, and in terms of expertise, there will be differences from one country to the other. And we also know that this outbreak does not respect any border. So with a very good regional approach, we know that we'll be able to respond to this outbreak in the most effective and the most efficient manner. So this is our model for responding to this outbreak. So we are using the different regional collaborating centers to drive our preparedness and response agenda. So you can see the different RCCs there. The one in the middle. Okay, so you can see the different RCCs on the screen there. And of course, it's all about coordination in terms of incident management system. Then, of course, when it comes to capacity building, it's also regional approach is the best bet. Even in terms of stockpiling, regional approach is the best. And one thing we're doing in that regard is the Peace and Security Department of the African Union. They have the different they have stockpile facilities in the different regions. So we are leveraging on that resources to move the stockpiling agenda forward. So, what are the take-home messages from Africa CDC to member states? 1, point of entry and surveillance, very, very important. We know that for now, for most of our country, maybe with the exception of Egypt and Algeria, we are not so sure. Virtually all the cases we have are imported cases. You know, so this underscores the need for proper surveillance at our point of entry. And this also explains the reason why, for this particular training, we are bringing people from the referral centers and from the point of entry. You know, so we need to tighten surveillance, and we have rolled out training in that regard, and we've trained more than 22 countries. And I think this week or so we'll be starting another training in Uganda with ICAO, you know, to make sure that our surveillance capacity at point of entry is at the highest level. 2, diagnostic capability. It's not enough to have the test kit. We know that countries can buy the test kit. So of what use is that test kit if you do not have the skill to run the test? Or you run the test and you run it wrongly, you know? So very, very important. So we are building capability along that line. And as I said earlier, on 43 countries have that capacity to test this COVID-19. So what we're currently doing is to roll out some sort of quality assurance, you know, program to make sure that you are doing the right thing. Because it's not enough to do it, but you also need to do it properly. So that is also one key message. And for you to also know that for each and every region, there will be one country that have the capability to do sequencing, you know, to analyze the genetic profile of the virus. And of course, stockpile of key commodities is also one message that I want to send out now. just this morning, I called my family because there was a rumor. I won't mention the country. So I said, please, can you get hand sanitizer for the kids because they will go to school. So my wife came back to me and said, there is no hand sanitizer anywhere. I said, what is happening? I said, okay, go to the hospital. The same story. So please, stockpile is very, very important. So as medical personnel, this is one of the key pillars of our response. So we need to stockpile those essential medical supplies, especially for infection prevention and control. Things like hand sanitizer, things like the mask, things like all these other PPEs, like goggle, like the cap, the gown, So we need to have stockpile of all this, and those essential are medicine as well. So it's very, very, very important because one, the supply is running low, the cost is running very, very high. So, and as member state, this is the least we can do for our people. If they go everywhere, they cannot get it. When they come to us, we should be able to solve their problem. So if you cannot do that, then we have failed them. So please, medical supply and stockpile, very, very key as we move forward with this response. Infection prevention and control, very, very important. We know that if we don't get it right, in the course of our response, we will be infecting others, whether knowingly or unknowingly. Either at the isolation facility, because, we've seen this in Ebola. You put a temporary holding place in the community. The infected and the uninfected, you put everybody together. So even the one that is not infected, before you know, he has also acquired infection. You understand? And even the continuity plan at the different hospitals, if you don't handle it very well, somebody comes to the facility with malaria, this person gets mingled together with somebody with Ebola or hemorrhagic or any of those viral hemorrhagic fever. What will happen at the end of the day? From malaria, it will catch COVID-19. So IPC is very, very important. And as I mentioned earlier on, we have started the training. We have built the capacity of 23 member states. We are currently working with 15 member states. And together with WHO, we'll also be moving a step further by training about 17 master trainers on the continent. 17. So very soon we'll be rolling out that, and we are seriously engaging with WHO, so that this master trainer can be deployed to each and every region or member state to provide the necessary support based on request. So IPC is very, very important. If you don't get it right, this will continue to drive the epidemic. And of course, funding. Very, very important. And see, this is one of the advantages of working together either as a region or as a continent. Because you know that when you come together, you're able to leverage more resources. You can imagine if we go together as Africa to go and talk to World Bank, just imagine what will come to the table. Now for me to go in alone as somebody from Ghana, what will I get? So we need to work together as a continent, or at the minimum as a region, so as we'll be able to leverage resources. And as member state, we also need to play our part. We should not just answer off and throw the ball into the hands of the partners. The partners cannot do everything. Because the issue is, if it's not important to you as a member state, why should it be important to me as African Union? So first and foremost, it should be very important to you. It should be a priority to you. You need to bring something to the table. Then I say, okay, fine. If you have done this, let me take it to the next level. So as much as possible, we need, work together, get the necessary resources. In fact, somebody said this is time for everybody to go for supplementary budget. Because this is not what was envisaged by everybody, So we need those resources, and let's knock on every opportunity, both collectively. So, I think I have 2 more minutes. So, just to wrap up, so these are the next steps for us at the Africa CDC. We'll continue to roll out training of trainers and all the key areas. We'll be targeting about 10 high-risk countries, but let me say that that list is growing. From 10, I think we have moved to about 15 now. because this is an evolving situation. You know, initially it was countries that have close ties with China, but now you also have to look at countries that have close ties with Iran, Italy, South Korea, and so on and so forth. Of course, we said the lab, we need to establish an external quality assurance program. It's not just to do the testing, but you need to be able to do it very well. Of course, IPC is also very important, so we'll be supporting member states to do that. We know that human resources is a big issue. We will be supporting member states with that. Stockpile, do your part. We will do our own part as Africa CDC, and based on your need, we will be more than ready or more than glad to support member states. But you need to bring something to the table so that we can complement. Then, last but not the least, we'll be conducting stimulation exercise. Even if you say you are good, even if on paper you have ticked every box, correct, we want to test the system and see whether what you have ticked is actually right. So we need to do that. So, colleagues, ladies and gentlemen, I think I've come to the end of this presentation, and I'll leave you with a quote from Kwame Nkrumah, and that statement was made sometimes in 1963, when he said that as a country, you are not able to achieve anything, you know, and even if as a country you have achieved independence, you are still not independent until all the other countries around you have gained independence. So meaning that if as a country you have the capacity to deal with COVID-19, you are not yet free from COVID-19 until all the countries surrounding you have that same capacity to deal with COVID-19. So, colleagues, ladies and gentlemen, obrigado, je vous remercie, thank you for your attention.